Dr. Vidhya, Dharani.
Good afternoon. I'll be talking about IIH in children. Pediatric IIH is uncommon. In children, the CS of opening pressure has to be more than 28 centimeters of water or more than 25 if the child is not obese and not sedated. The aim of this study was to understand the clinical profile and treatment outcome of IIH in children. A retrospective study where the electronic medical record of 7 children were analyzed. The inclusion criteria was children less than 18 years of age with a minimum follow-up of 6 months. Any intracranial pathology and those children with renal failure were excluded. The age ranged from 1 to 17 years, with the youngest child being 1 year of age. The male-female ratio was 4:3. 4 children in this study were obese and 3 had a normal BMI. 5 children came to us within 1 to 2 weeks of onset of symptoms, while 2 children came a month later. The most common presenting symptoms were headache and double vision. 5 children had best-colored visual acuity and color vision being normal, while it was defective in 1 child who had fulminant IIH. The 1-year-old child was able to follow and fix light. The common signs what we came across was abduction limitation in 6 patients, bilateral disc edema was present in 6 patients, and was normal in 1 child. The disc was normal in 1 child, indicating IIH without papilledema. The visual field defect most commonly we came across was enlarged blind spot. The child with fulminant IIH had consecutive visual fields. Even though there is no normative data for OCT in children less than 18 years, it is still done as it helps in monitoring response to treatment. Neuroimaging showed widened perioptic CSF space in 6 patients. Surprisingly, no features of raised ICP were seen in that child with normal optic disc. Management, lumbar puncture was done all to record the CS opening pressure, which ranged between 25 to 40 centimeters of water. All children received tablet acetazolamide. The older children were also given a trial of furosemide, oral glycerol, and injection mannitol. These medications were gradually tapered based on resolution of symptoms and disc edema. Bilateral optic nerve sheath fenestration was done in the child with fulminant IIH. The treatment duration varied between 3 to 9 months. Healthy lifestyle, weight loss was encouraged in each visit. All had good recovery except the patient with fulminant IIH. 1 child had recurrence of the disease 2 years later following excessive weight gain. So the table showing synopsis. Moving on to discussion, IIH as an adult is always a diagnosis of exclusion. Its pathophysiology is unclear. The theories surrounding CSF dynamics either include decreased CSF drainage or excessive CSF production. So is the pathophysiology in children different? Well, Margaret et al. They demonstrated lower levels of CSF protein in prepubertal children, reflecting overproduction of CSF rather than a reduced drainage. What about the gender predilection? Various studies by Genzi et al. And Balser, they said that in the prepubertal group, there was no significant difference. That means there was an equal incidence between male and female, but as age advanced, the incidence was more among females, especially in obese postpubertal females. In our study, 4 children who were less than 12 years and prepubertal were all males, and all the postpubertal patients were females. There is an association between pediatric IIH and prevalence of obesity with increasing age. This thing was supported by Sheldon et al. He said that the younger the patients, the BMI Z values were normal, but in early adolescent and late adolescent, they were hovering around the overweight and obese reference levels. In our patient, 2 children who were less than 12 years and 1 patient in the postpubertal group had normal BMI, rest were obese. The most common symptoms children can present with are headache, tinnitus, and diplopia. 50% of children are symptomatic when compared to 20% of adults. Optic nerve edema is the most common sign. Rarely, children can present with symptoms of raised ICP without papilledema. Management is multidisciplinary and must include a nutritionist. Mitigation of symptoms, preventing permanent vision loss is the goal. No RCT studies in children are available till date. Recurrence can occur, especially in those children who lose weight initially and regain it. To conclude, pediatric IIH is uncommon and less frequently reported. There are multiple diagnostic snags which we come across, especially those with diagnostic investigations such as LP and for MRI, which can need general anesthesia or sedation. Despite these hurdles, accurate diagnosis is mandatory to prevent permanent vision loss and poor quality of life. With obesity emerging as a major risk factor, adverse effects of obesity must be there in primary caregivers, and a healthy lifestyle must be emphasized. Thank you.
Definitely a difficult study too, because pediatric IIH very difficult to measure the CSF. How the CSF was measured? It was by the pediatric neurologist?
Yes, pediatric neurology. All children were referred to pediatric
And all
neurology.
were done under sedation?
No, only those 5 years, 1-year-old child and 12-year-old child needed sedation. Others cooperated.
Because you have written headache and diplopia was the main symptom.
Yes, sir.
How that 1-year-old child came to your department?
The presenting symptom was, it was referred to us by the pediatric neurology department, pediatric ophthalmology department. The sudden onset of face turn, that's what the parents noted. The child had an AHP, for which they brought to the eye institute.
And MRV with contrast was done in every patient?
No, sir. A plain MRV was done. If there was any suspicion of it, then a contrast was administered. So all these patients on a basic run through the MRV was normal.
So that means all the MRVs were normal?
Yes, sir.
No sinus involvement?
Not at all. Not in one child.
Involvement was not there?
No.
Any hypoplasia of transverse sinus? Any stenosis?
Not at all. No.
No. Quite strange.
So how did you check the vision?
The sentinel starting, basic sentinel starting was done. That was used to check the visual acuity. Humphrey's perimetry for visual field assessment, and Ishihara's chart for color vision.
So like you wrote BCVA is normal, no? So usually in studies you have to mention what is the BCVA which was noted, either a range.
Okay.
You have to write that, which method was used whenever you're conducting a study. Like you can't write it's just normal or defective like that. It has to be written a proper
More
method.
elaborate.
Yeah. So one child you said had normal optic disc
Yes.
and normal MRI also.
Yes.
So how did you suspect IH in that child
The
then?
symptoms were of raised ICP, headache, diplopia, nausea. The child also had tinnitus too. With this, we neuroimaged. Neuroimaging was normal. So when we did go ahead with the lumbar puncture, there the CSF opening pressure was 30 to 4 centimeters of water. Thank you.